11 o'clock on the dot,
All
but
right. So all you'll need to do is just end the meeting when you're done, okay?
perfect. All right.
Thanks,
I
man.
think I can do that.
All right. All right. Put a lot of faith in you.
Well, the problem will be if I end it before I'm done. That's more likely to happen.
All right. Thanks.
Thanks. All right. Well, a few people might be trickling in here, so I'm just gonna refill my water glass and then we'll dive in here. It's 11:02. Got a small group today, but hopefully this will be something. Uh, I should start with Dr. Calgill is not here to lead the session today, so for better or worse, he's turned the reins over to me for the day anyway. I'm Jethro Forbes. I'm small animal emergency critical care at Cornell University, and I lead and direct and establish the extracorporeal therapies and blood purification unit here at Cornell. For those of you guys that don't know me, I've been involved with extracorporeal therapies for about 15 years now, off and on, but pretty well straight on since I started our unit in Connecticut, the first unit that was in the state. That was back in 2015, 2016. But before that, I was lucky enough to have some really amazing mentorship out in Seattle from Linda Barton, who ran our unit out there. And I've been fortunate enough that folks like Dr. Calgill, Dr. Langston, Dr. Foster have allowed me to tag along and pick up and learn as much from them as I can, and email and text and ask questions at all times of the day and sometimes night to help me at least pick up a little bit of what they've got knowledge base wise. I know there's a few folks here that are in the academy, and then a few that are I think just come for rounds. I am. I've got a couple of thoughts for today. I've got a case that I'm willing to put out there and share and seek some feedback and hopefully make it a little bit interactive. I may call on some folks as well, since some of you guys have names up there. If anybody feels comfortable with their cameras on, it's always a nice feeling to see some faces out there. Oh, Andrew, thanks, man. Um, and yeah, so I'll dive into that unless anybody has something interesting that's going on in their unit right now.
Jethro, I have a kind of question for the brain trust. If you've
All right,
a
it's just
moment.
me here today, but yeah.
But so we had a hemoperfusion case on Monday that it was a dog that got in about 200 mg per kg of carprofen. And uh, once we got going, it went okay. My biggest question actually is around the catheter. So I can share my screen if that's okay and show you the placement rad. But our biggest problem with this is that we were just like, we couldn't get good flow, and we ended up having to, we use a vet rescue, but I was using initially an Amlogic device, and then after that clotted and I lost my first circuit, I switched over to the vet rescue devices. But part of, I think, the reason that I had clotting, one was my own heparinization problem, but the other, I think, was trying to get a fast enough flow. And my challenge with that was all related to the inability of the catheter to pull. I kept getting like too high of a negative pressure on the inlet line. And so let me see. I
Are
don't
you able
know.
to, can you share? Or do you need me to make you co-host? I'm not sure if sharing's
I don't know if I can
here.
share. I don't. Oh wait, hold on. Maybe now.
All right, I just made you co-host, so I think you should be able to share now.
Okay.
Are you able to give us kind of signalment size of the dog?
Sure. It was an 18 kg, 10-year-old male castrated poodle.
Okay.
So it was the RP saw the case, so referring partner saw the case. They vomited the dog. Dog ate 4,000, so 4 grams of carprofen, ate an entire bottle essentially, and they got 4 pills and then like 3 cheese sticks that were still in the wrapper. And then the dog defecated out some foil right before the procedure, so like clearly had gotten into things that he shouldn't have.
Hmm.
I apologize. I'm trying to figure out how to actually share my screen. I'm used to using the Teams platform, and oh, there we go.
Yeah, at the bottom should have a little green up arrow with the word share. Then you just pick the screen that you want.
I'm gonna see. Okay, I've got to jump off and jump back on for Zoom to see that I can share. I apologize.
Oh, that's good. No
I'll do
worries.
that. I'll be right back.
All right, see you in a minute. All right, while he's signing out and back in, anybody else have anything interesting going on? Oh, he's coming right back. That must be him there. And this is going to be interesting. I mean, catheter access and blood flow rates are depending on. I'm going to be curious to hear about what type of catheter they had, and we'll see what the placement looks like too. I had one last week as well. Also an NSAID, an ibuprofen overdose, that I struggled with access as well. So these are pretty common problems, and there's a couple of maybe some pearls to share amongst the group, and see if we can at least share in our own misery. But I'll throw out any of my troubleshooting uh, strategies as well. And then again, it'd be always lovely and welcome for anybody else to jump in as well.
Jethro, while he's looking to find the image, I can at least share it was a Mila dialysis catheter. It was a 12 French, 25 centimeter. And when we measured the dog, we were a little torn between the 16 centimeter and the 25 centimeter for final placement. We were just worried that the 16 might be just short enough that we wouldn't get the flow rates that we were hoping for. So we went with the slightly longer one. I just don't like, well, I'll let Drew share their radiograph, but when we were looking at it, we were, without biasing the audience, we were debating where it was located and if that was part of the problem. And we did do some various tricks to try to, alter the flow by like tugging on it and pushing on it and flipping our access. Just had a lot of that initial trouble until we decided to pull it out some.
Yeah. And is that Mila? Is that a polyurethane catheter?
I want to say yes, but I don't know that off the top of my head.
I'm pretty sure most of them are, and that's nobody from Mila's on the call today. I don't want to disparage those catheters, but I'll have a few things to say about that when I.
We've done a lot of the procedures, all the procedures we've done, we've used the Mila catheters. We have some med comps. They're starting to be just past their expiration date, and they were hard to find for a while. So we're debating whether they get gas sterilized or love anybody else's thoughts on, is anyone trying to keep those catheters alive because they were hard to get, but we have some. We are just comfortable because all of we only do short-term procedures like MNC collection and hemoperfusion, and so we've just used the Milas to save the other catheters, but they again might be better options for some of these procedures.
Can you guys see the image now on my screen?
We do, yeah. We've got
Okay.
the right lateral view up here.
Awesome. So yeah, to me, I was like, oh, it looks like we've got decent positioning. What we couldn't tell is, did we like dip into the right atrium in a way that it prevented us, like, or that it like got sucked up against the heart wall, the muscle wall. By the time we ended up pulling the catheter out, probably about 4 or 5 centimeters, and then got great flow toward the end of the procedure. But yeah, like Jay was saying, we were really torn between what size to put in, because this is a 25 centimeter catheter. 16 probably, would have put us somewhere here, which ultimately is probably where we ended up. Maybe not quite, maybe we're here, but I don't know. Like this didn't seem like poor positioning to me, just looking at the placement rad, but it gave us a ton of trouble.
Yeah, yeah. And what kind of flows were you able to get at this position versus when you pulled it out a bit?
Um,
Even ballpark. I mean,
well, like we could, when it was like this, we were having a hard time, like even getting it to flow. Like literally it would like on, off, on, off, on, off.
I think we
Which
were
is how we
starting.
ultimately clotted the first circuit.
Yeah, I think we were just at like the amping up to like 100 mils per minute on the Purify device.
Like
okay.
not even. And
Yeah.
eventually we ran it. When we finally found good position, we were running it at like 250 mils per minute.
Nice.
So
Okay.
we got good flow by the end, but well,
No, it wasn't really
not really.
250.
It was more like 150. There's a math error in our programming that we've now learned on the software side of things that we had to compensate for. So it's probably like, yeah, about 150, 175 mils per minute by the end.
Okay. All right. So, I mean, it sounds like, I mean, from that, and I know you touched on a little bit of the heparinization strategy and some challenges there maybe, but with the repositioning, it sounds like I mean, you didn't get the 250, but you were flowing pretty well. Just, so process of elimination. I mean, I'll take you through. So I treated it was a 6 kilogram dachshund last week for the ibuprofen on the carbon hemoperfusion device, and had very similar challenges with what you're describing with his catheter. And his was a Mila, it's an 8 French, 16 centimeter, I believe, polyurethane. And I'm historically biased on the polyurethane catheters because they just don't the memory they have for kinks or abnormal kind of folds has just given me enough problems and enough patients over time that I like swear under my breath as I'm placing them because the silicone ones just don't give me the same problems as the polyurethane ones do. And so for this dachshund, I had almost a very mere, description of those pump flow challenges and access pressure alarms felt like every 2 seconds. And I think his was in a little bit long, not a little bit long, but probably about similar to where yours is placed as well. And what I actually found with him is right at the insertion site, because of where I was, maybe a little bit high up on his neck, trying to not have it quite so deep, there was actually a little bit of a bend there, and it had enough memory there that I actually had to pinch the part of the catheter where it attaches to the hub, and that got me the flows eventually. But I was in the same boat. I got to pull this out a little bit, and actually I did pull it out a little bit as well. And so some combination thereof. So again, they're in the background of my mind. I'm like, oh, the polyurethane. But those are the smaller guys. I've not actually used the bigger sized polyurethanes because I've had access to the med comps, and the silicone versions really just do me well. So I've also had some of those catheters that, even though I'd be happy with that placement as well, it looks like it's probably just a little bit down into the right atrium there. But sometimes just, flow, rheologic effects and how everything's moving in there. Did you guys try reversing flow in that spot?
Yeah, that's what we did first. And
Mhm.
we ended up actually the entire procedure having reverse flow. And it helped, but not enough that I could run the entire procedure like that and get good flow rates.
Yeah. So, my inherent bias towards placing of my catheters anyway, and again, anybody else speak up at will, is to bury them, just for the sake of not having something flopping around to kink or to, reduce the chance of infection. If I'm leaving it in for 24 hours, and I want to get like that sweet spot, like right at the cranial cava in the right atrium, maybe I should be a little more gentle and leave some of it out, for avoiding issues like this. But I would have done the same thing, which is to place it deep, bury it, and then if I needed to kind of back it out like you guys did, which similar to again what I did in our dachshund last week, with the addition of having to pinch it at that insertion site on those polyurethane ones. So from a catheter placement perspective, that story with where it's sitting there, I've certainly had those side ports, just for whatever reason, it's just enough flow or whatever the natural flow through that chamber has led it to push up against the sidewall, and I've gotten those pressure problems as well. So outside of all the other troubleshooting you did, like going through the reversing, making sure your anticoagulation strategy was sound, and then modifying where it's sitting in there. Those would have been the same things that I would have gone through, and ultimately you guys got enough flow to do the treatment, it sounds like.
Drew, do you want to speak to the original sort of upside down configuration that wasn't letting us flip? Remember,
Yeah, I mean, I think this was mostly like a placement issue. When I placed the catheter, it went in a way that, like, when I went to suture it, it looked like it was upside down. And so I tried to rotate the catheter and I couldn't get a full, like, this is a weird analogy, but like, when you place the E-tube and you're like, okay, it flipped, right? And you're like, I'm in the right spot. I'd never got that feeling of like rotating the catheter and having it seed like really nicely and flat against the skin. And I don't know, is that also because it was in the right atrium and I couldn't get the full movement of the catheter? So we were also wondering if that was part of the problem. When we were able to finally back it out, and it probably was in the lumen of the cranial cava, like then we could rotate it nicely and it flowed. That also contributed to the better flow rate. But it was just like I'd also never had one go in where I couldn't manipulate the catheter at all once I'd placed it.
Yeah, I've had a couple that are rolled as well, and when I go to try and like lay it flat with the suture wings and all that, it's like it's really a struggle, and that I have found has also impeded some flow as well. So it sounds like you guys like hit the trifecta or even more of all those different challenges in this catheter. I see Carolyn's on. I don't know if you've been following any of this, Carolyn. You've probably placed more catheters in this whole room combined.
Sorry, that was my dog that barked. There was a dog on the TV, and of course, he doesn't stand for that. I'm sorry, I jumped on this call a little bit late. Jeff asked me, Jeff was like, "Are you around?" And I was like, and so I jumped on. I missed it. What were we treating this dog for? And was this like did he have a really thick neck at all?
It's a 18 kg poodle that
okay.
had a 200 mg per kg carprofen exposure.
Okay.
There's nothing weird about the dog.
I literally just got home 20 minutes ago from doing the same thing. Ours was a little dachshund mix, 200 mg per kg of carprofen. And believe it or not, I literally had the same problems you were having with my catheter. So our catheter placement wasn't quite as deep as yours, but I find looking at the x-ray that I saw, the rad, like I said, we ran into the same problem. And this literally today, this dog came in and was dry. Like his PCV was 63 with a total solids of 9. And I could not get, when I was testing the catheter flow, my access line was sticky, what I would call sticky. And I think because the dog was a bit dry and where the fenestration openings were, I think that it was just enough that when I was trying to pull pretty hard on it, it was pulling itself into the wall. I think because those fenestrations are pretty high up, and it looked like your fenestrations were kind of right at that juncture of where the cava and the right atrium are. And so I'm wondering if the dog was maybe a little bit dry, that you were just pulling right there, and that's why you were getting some flow from the return side. I had to do the same thing. I had to switch my lines. And then we rehydrated the dog, and by the end of the session, when I went to kind of go and flush the catheter and everything, the access port was pulling really, really well. And I was like, oh, I should have just rehydrated the dog a little bit more. But I think my tendency and my especially for these one and dones, we tend to bury them. If we can't get it really squarely into the right atrium, we shoot for the cava, the caudal cava. And I find I get much better flows that way than when we've tried to put it into the kind of get it into that junction of the cranial cava and the right atrium. We just get better flows. Generally speaking, the older kind of dogs that may have other pathologies, I'm not going to try and I'm going to just try and get it into the right atrium and keep it out of either the cranial or the caudal cava. But just speaking of the catheters we like, I agree with Jethro to a point about silicone catheters. I really do like them. For these one and dones, I tend to use the polyurethane because they're less expensive. They do have a memory. I won't lie, my very, very favorite catheter is a MedComp catheter, and it is polyurethane. It is called the Trio CT. It has 3 ports, and it is oblong. It is not actually ovoid. I'm sorry, it's ovoid, kind of oblong. It is not circular. And it's a little bit more difficult to get in, but the shape, the way the catheter is shaped, it is 2 full Ds, like very full Ds. And so I have never, and I'm knocking on wood right here, I have never had one of those catheters actually not been able to give me good flow. We treated a dog yesterday for over 1,000 mg per kg of ibuprofen toxicity, and we had that dog flowing at 350 mils a minute. The dog had a seizure 10 minutes into the, and that catheter never blinked an eye during that seizure, kept on flowing, no problems with pressures. And they don't tend to kink. Even when I have found a little bit of a bend or a kink, I pull out the skin or whatever and move it, and it hasn't given me problems. And the nice thing is I have never not been able to get them from MedComp. They've never been on back order. But they only come in 13.5 French, and they are 24 centimeters or 30 centimeters. So it's generally speaking your dog's above like 18 to 20 kilos. But I mean, I don't know that I have anything more than what Jethro said. I have a tendency to bury all of them to the hub. We do all of our placements now in fluoro. So we place the guide wire, we measure, and then based on that measurement, we kind of pick a catheter that's closest, and we'll always kind of we'll generally err on the side of longer rather than shorter, so that it'll go into the vena cava, the caudal cava.
Yeah, Carol makes a great point on the fluid status, intravascular volume status as well, just in terms of the rheology of blood flow in there and how sticky things are. That's a great addition to the conversation too.
Yeah, I think in hindsight, our dog was drier than we thought because we just thought he was like ate the carprofen, puked him, not that dry. But I think once we put the rest of the story and he was like pooping out foil and cheese sticks were coming up. Like I think once we really sort of tuned into his hydration status, we ended up giving him fluids, and we did end up giving him blood as well because we clotted that first circuit. Luckily, it was a small one, and his flows were also better after that. So it may have just been the perfect storm of hydration status, placement, and we eventually got to where we were. But as you're learning to do this, you sort of were like, how have we gotten this many complications? But it does sound like it makes me feel better. I don't know how you feel, Drew, that at least these are things that you just have to work through, and we sort of were able to at least try to work through them and get them where we were. I think our biggest fear was just like, in my mind, once you back one of those catheters out, you can't put it back in. And so that hesitancy to reduce the depth of the catheter and then negatively impact your flow, in that moment. But it ended up being the right thing for us to do.
Yeah, I think part of it too is like we're just new enough at this. Like we went through academy like finished 2-ish years ago just over a year ago. And have had a handful of hemoperfusion cases, but not a bunch. And so some of this is still the first time we're dealing with some of these complications. And it felt like all of them happened on this patient in particular. So I think every time we do this, my comfort level and my ability to troubleshoot gets better, but it's still, I'm like, am I doing the right thing? And there's nobody else. It's me and Jay here. We did all this at the same time together. So are we doing the right things? Are we missing anything? I'm happy to continue to learn.
The,
And
the
I guess,
other
go ahead, Carolyn.
Sorry, Drew. The other thing sometimes I'll do is along those lines of talking about like when you get that catheter kind of sucked up against the side of the vessel wall. One of the things sometimes, if you've given it a good hickey and it's attached itself pretty well, sometimes I'll take a 10 cc flush and give it a good hard flush, because sometimes you really need to flush it pretty hard to get it to release. And then start my blood flow back just a little bit slower and then ramp it up.
Okay.
But that's just a tiny tip I've seen that in my experience is sometimes.
I think the other question that I sort of have, not necessarily around the catheters, but around these cases in general, we've had a few NSAIDs and we've had a few that have gone great. Like they come in, they don't do well, or they're not looking good. You put them on the machine, they look great after, and then they go home fine. We've had more of them that like they either end up with like terrible GI bleeding still, despite having done the therapy. The dog that I'm talking about today, like has terrible pancreatitis and a bad AKI. And I'm kind of in this, like, we're 5 days out, right? I did a procedure on Monday. Today's Friday. His AKI is progressive. He's more icteric. Like, how much of this is normal kind of post bad toxicity exposure, despite hemoperfusion, and how much of this is just like kind of bad luck for this dog? I don't have enough cases. I haven't done enough hemoperfusion to know, like, is this something I should just expect in these cases? I think we all have these rose-colored glasses that we're like, oh, they got into something, we're gonna go suck it out and they're gonna go home tomorrow and be fine. And in general, that really hasn't been my experience, but I haven't had a bunch to compare to. What do you got?
I think, I mean, you threw out so many other contributing factors in this dog in particular. I mean, the pancreatitis, I mean, we'll put that over in the background with all the other crap that he ate. I mean, I almost expect the GI signs, depending on when, I set people up to say, listen, at best, hopefully we got this soon enough, we're cleaning out well enough that we're gonna avoid the acute kidney injury into things. But I set people up to expect that there's going to be GI consequences, just given the timeline. And again, in this dog, everything else that it ate as well. Because I don't know, and I don't want to, I don't set my owners up, and I'm sure you guys everybody have relatively, calm expectations as well, or realistic, that there may be some GI stuff to follow. And that's definitely something, even when I get them early, I still kind of coach them to say, and kind of mentally, I'm prepared for not being a total magic bullet, silver bullet, magic potion, whatever. The rest of it, how bad's the AKI today?
So he came in with a creatinine of 0.7, and now it's steadily increased. Today it's 4.3, which is not terrible, but it just keeps going up. His T-Billy also was like normal when he came in, and now it's 6.6 today. So it's like, but I can't separate it from the pancreatitis. His CPL was like 1600. So he's got bad pancreatitis, and that in and of itself can obviously do this. So I'm having a hard time kind of separating the two and trying to give this family a prognosis to say, like, I know that we just did this big procedure on Monday and you've spent 5 days in the hospital. Do we keep going? Do we not? I mean, some of that is up to them and their financial abilities at this point, but like, I don't have enough cases to say like, hey, these are ones we should hang on, and this may be other things and not necessarily the carprofen.
Yeah.
No.
I mean, I can't help but throw, I'm sure you guys already like lepto tested and like went through all the other stuff as well. In the pank, you've got all these comorbidities that could be contributing here. Is he hemolyzing as well, or do you think the bilirubin's like from the transfusion? Do you think the bilirubin's, strictly?
I mean, he got the blood on Monday, and it's been really 3 days till it. Today was the big jump. I think we're too far out probably from that transfusion.
Agreed. Yeah. I mean, in terms of, the conversation I would have at this point is, we did the best to decontaminate and try and avoid the toxicity effects from the NSAID, and all, just on the, the softer side of things, amongst friends here. I'll tell you, I don't know if it matters how many of these you've done, and you guys are, right up front about saying, hey, we're learning with each one, and we're young in our pathway with this. This dachshund I did last week, I was beating myself up left, right, and center on that dog as well for the catheter. I'm like, oh man, I suck at catheter placement and all this other stuff. Like even at this stage, like I'm hard on myself for it, unnecessarily, because these are, as Carolyn said, and I shared in your guys' experience, like everybody's had these terrible catheter experiences. So from that standpoint, I think with that amount of an overdose, allow your guys a little bit of grace despite the complications and the bumps in the, learning and getting good at the procedural end of it. You decontaminated in a really great way because we've got hemoperfusion devices. And so despite how things look today, I mean, I would hold on to as best as we can the message that we did good by the dog by getting at least some or a lot of the NSAID, the carprofen out of the bloodstream, despite where we're at with liver and kidney and GI stuff now. As hard as that is. And looking ahead, I'll remind owners of that, almost to remind myself of that too. Sometimes, looking ahead now as far as the rest of the picture for the dog. I mean, we're kind of in the same boat as if we didn't have hemoperfusion, in terms of prognosis and waiting and supporting and giving it all the great supportive care that you guys know. You're experts on that, and that's kind of independent of the hemoperfusion at this point.
Thanks, I appreciate that. So definitely been a learning case, but it's
it's hard.
Yeah.
Well, and especially, I mean, you and Jay have been doing this. I mean, take the hemoperfusion out of it, but like ECC, right? Like you guys learned the hard way on a lot of other stuff too. Some of those lessons are a little bit further in the rear view, but they're a part of what we do, which is hard to swallow sometimes, for sure.
Yeah, I think that's where the literature is a little bit like enthusiastically positive. And I don't know if just some of the case reports and the reports that are out there were just young dogs that really, people were on it and they got all the things, but it like some of the literature suggests like it's like, oh, they just had this, they're done, they turned around. And we've had a few of those. We've had a few that were massive ingestions, at least based on what we thought and we calculated, and they just like left the next day like nobody, like nothing happened. And then we've had a few of these where, it's still high enough. And to your point, it is more probably the comorbidities or the other things that gets them. I think it's just us trying to understand, since not all the cases that everyone's doing out there are published, what is the norm, how many of these are walking out the door, with no problems versus having some problems, or is it just like any other toxicity? It's the comorbidities, it's the dog's epigenetics, his age group, some of those things that end up ultimately affecting the prognosis, just because we're trying to balance the cost of some of these procedures and the potential outcomes. But yeah, to your point, my take is obviously without this, these were dogs that didn't used to survive or, went up in a ball of flames day one, and we're at least at day 5, for better or for worse.
Yeah.
Hey, Jay, Andrew, thanks for presenting that. Sorry to hear about the challenge, but as Jethro said, it is part of the real world. Couple questions for you. What was your starting ACT, or what do you guys normally target for starting ACT?
Not high enough is the short answer to that, Jeff.
Yeah. Okay.
Yeah, not high enough. dog was
So-
definitely more hypercoagulable than we appreciated, and I think we probably only got to like
I think 120. I think our target really is 180. And we foolishly in our rush to get started, we're like, 120 is close enough, and then regretted that immediately.
Yeah, and if you kind of get that coagulation cascade going, it's almost impossible to reverse it.
Yeah.
So that was one question I had, and then the other point I would make is that, and Carolyn maybe would chime in on this, but carprofen is sticky. So of the NSAIDs, you can look at ibuprofen and say, yeah, it's 98, 99% protein bound, and so is carprofen, but they behave very differently. So that instant gratification that we get with one drug at a particular dose, we can pat ourselves on the back and say, oh, that was, they should all look like that. And that is not the reality. Carprofen has a higher binding affinity to protein. It comes out slower. And I think, clinical signs resolve slower, all that kind of stuff. You have to appreciate that not every drug behaves the same. And then at a high dose, it just makes things worse. So I think there may be some contributing factors there. Carolyn, did you have any advice on carprofen specifically?
So, our expert on that is Emmanuelle, of course, Emmanuelle Petit. So we've been talking about this and talking to you and your engineers, Jeff. We're finding that, yes, it's super sticky, and that we, instead of aiming for blood volumes per se, how many blood volumes we're going to process, we aim to do a minimum session on carprofen dogs of 4 hours, just because we think that it just takes going through the carbon. It just needs to process through the carbon more to get the carprofen off the protein and onto the carbon. And so it just takes a few more passes and extra passes through. And so we aim for a higher QB, but to aim for a minimum of 4 hours in our sessions is generally what we aim for. And oftentimes we have animals that get, stressed and get upset. If we can make it past 3 hours and make it over 25 blood volumes, that stress patient, we may end the session early, but we really find that we like to try and at least extend to 4 hours with those guys. As to the heparinization, the thing that I'm finding, and we've ran into some problems recently, and Jeff probably knows this about us. We've been using his columns a lot, and probably we're one of the clinics that are using them the most. But in the last few months, we've run into some real problems with clots developing on the screens, mostly on the bottom screen. And I'm finding, and this was primarily when we were blood priming the column. But what I found is that you have to actually as much as there's anticoagulation in blood product, like whole blood that we were giving, there's citrate. I think the citrate's coming out way quickly. And so what we've been doing is we've been actually quote unquote, bolusing our blood that we're using to blood prime with heparin. Usually at least 20. I take the weight of the patient that we are putting on, and I'll usually give the blood bag like 20 units per kilogram of heparin into the blood bag, because anything that got blood primed, almost always we developed pretty significant clotting on that bottom screen. And so the last 2 times that we blood primed, we actually did the heparinization, and we actually had no clotting. But I think what's happening is just even a few microclots get onto that screen. And if you are not, if your ACT isn't really pretty high to begin with, you get 1 or 2 of those little microclots, and through your session, they'll grow pretty fast. and you'll end up with pretty significant clotting on that screen. And once that happens, you just can't save the column.
Yeah, that definitely happened to us. We started with an analogic, and we lost it very quickly, like for all the reasons we talked about, catheter flow, all those kind of things. And our initial heparin was not hardy enough, with just everything going on. But yeah, I think it just our flow rates were slow. It started to get clotted, and then to your point, Carolyn, it clotted very quickly after that. I'm just curious, Carolyn, when you say you're doing it for 4 hours, like ours ended up being pretty close to 4 hours. I think we were at 18 blood volumes, when we switched over to the vet rescue devices. But what blood flow, like my understanding from the Amylogic recommendations, the blood flow rates that they were recommending was somewhere in the 100 to 200 mils per minute. Like when you were saying you're using faster blood flow at the 4 hour carprofen treatments, what kind of blood flow rates are you talking about?
So, unfortunately, the Amylogic small tubing kit, the maximum blood flow rate is 80 mils a minute. So, for instance, the dog that we just finished treating today, that dog was just about 7 kilos. So we ran it on a small tubing set with a small Amylogic column. And we just ran that dog at 80 mils a minute. So I knew that we were about 50 to 55 seconds in the circuit. We just ran it at, like, I started the dog at 50 mils a minute, and within probably about 10 minutes, we were running at 80 mils a minute because she was tolerating it really well. And in 4 hours, we were able to process 35 blood volumes on that dog. For instance, the ibuprofen dog that we treated yesterday was a husky that was 27.5 kilos. And again, we treated 30 blood volumes on that dog. He was neurologic clearly, but we treated 30 blood volumes on him, and we were running him at 350 mils a minute.
Maybe Jeff can comment on this. Is there a max flow rate for? I thought, and I don't know, Carolyn, we're using the 300 device on the bigger husky versus the 100.
Yes, we did use a 300
Okay.
device on him.
Okay.
We have done flows through the small device at like 250 to 300 mils a minute. In talking to the engineers and so on at Amylogic, my understanding is with the Revive pump, the rate limiting element is the tubing kit. And their medium tubing kit, the maximum flow rate is 350 mils a minute. Beyond that, you're going to be kind of compressing the pump tubing segment too much, and you're not going to get proper flow. So as long as we're getting proper flow, based on their manufacturer recommendations, we've flowed them on a big dog like that. We'll flow them at 300 to 350 mils a minute. But Jeff might have something else to say.
Well, no, I think you hit it on the head. There really isn't a limit on the columns per se. Of course, there is. You do lose some efficiency, some adsorption efficiency as you increase flow rate, but I guess we kind of consider it negligible. More important is to process as many blood volumes as the catheter will let you process. So, as Carolyn pointed out, on our small tubing kit, it is restricted to 80 mil per minute. And I know you guys weren't using our pump system and our tubing kit, but it's the tubing kit that the pump segment that actually goes in the peristaltic pump. If you increase the RPM of the pump, it still won't give you any more flow. It just maxes out at 80 and then it just cavitates. So that's the restriction. It's not the column.
Well, that's good
Yeah.
to know. Like, so then it sounds like people for these sticky carprofens are kind of pushing that 15 to 20 blood volume that we've used for other NSAIDs to closer to 25 to 30 if the patient's tolerating the procedure and the flow. Is that the general feeling?
Yep.
Jay, we did 30 blood volumes on that dog.
I'm guessing you did right by the dog. I mean, that is a sufficient treatment, no doubt. But yeah, sometimes they don't. Sometimes they don't all work out, like you said, with rose-colored glasses like we want them to. But carprofen's a tough one. You know, baclofen. I know Tufts has treated now quite a few bromethalin, and those really are difficult cases as far as the outcomes. To get good outcomes with some drugs at we got to keep in mind what the dose was and what the time of exposure was. The longer it was from the time of exposure, the higher the dose, the harder they are. We get used to the easy ones, right? Acetaminophen, you can blink and all the acetaminophen's gone and the dog's fine. But some drugs are just harder to deal with.
I'll toss out there, and now Drew and Jay, it sounds like you guys are using the polymer bead devices as well. They do have, and you guys know this already, I'm sure, they do have some data about how much dwell time needs to be at play, and so there are some limitations on blood flow rates through, I think, those devices to maximize absorption. I don't have those numbers off the top of my head, but they've got them available too if you need them.
Yeah, I can share with this group too. I don't know if anyone else is using the Purify system. They just identified that with their extra small and their pediatric circuits, the software in the program was set for the regular circuits, and we found out pretty quickly when we were doing some gravity primes that it was lying to us, because it was like, you have processed this much, looking up in the IV bag, like, no, we have not. So I think there's some software updates too, which was, again, to compound our lovely procedure and all the complications, we suddenly realized we were actually not flowing at the rates we thought we were flowing at for a brief period of time. So there's some quick math errors that were happening that we then corrected. But just for general knowledge for this group, or to share with others if they're using that, there's a software update coming soon, which will correct that problem.
Thanks. And yeah, again, just to focus on the learning's always hard. And especially when they're bumpy this way. The case I was going to share with you guys, and we won't have time for it at this point, was one I lost a patient, and it wasn't hemoperfusion. It was a lily cat, actually. And so I was going to take you guys through some of the process of that, and you know what I learned the extremely, obviously, heartbreaking hard way. These things still do happen. There's still a lot, unless you're. I would venture to say even Calgill learned something with each case. Even Carolyn's still learning. There's still bumps, and there's still things. They're like, oh, I knew that, and I either didn't think about it in the moment, or you know what, actually I didn't realize that. Or man, I thought I was doing better, and this was a case where I'm pretty sure this cat experienced disequilibrium syndrome post treatment, and I'm like, I knew that. I had my dose of mannitol ready to go and on the treatment sheet, and it just happened too fast. So there's still some of those hard lessons that come with this, but definitely, pat yourselves on the back for all the good things that you guys are doing too. It can be tough sometimes. Sorry, Jay, unmuted.
Yeah, I was just saying we appreciate this group, because I think without this sort of community, like, you do get in your head. So, and even while we're doing the procedure, we're like, we're gonna talk to them at RR. Like, the second we were like, we have questions, maybe other people have answers. So I appreciate being able to get this and get the feedback, because it does sound like, even at Jeff and Carolyn and your point, some of this is also, we're learning as we go, and so the neat version is hemoperfusion treats these things. The messy version is, yeah, not everything's treated equally, and timing makes a big difference, that kind of thing. So thank you guys for your feedback today. It's very helpful.
And we learn from each other's experiences too. Like we're learning from you guys as well. And how can we be better coaches, and what can I do in my own practice too? I threw my number in the chat there for you guys or anybody else as well. And I think anybody that's already spoken up on the call is pretty generous with time and learning. And I think, as you pointed out, it is that kind of community. We've got to help each other grow and do better.
We certainly appreciate that, and there's just not that many people, right, that are doing this and are coming together to talk about it. So we don't have any other direct resources within our own organization right now. That's not entirely true. There's a group out in Salt Lake that's different time zone, and just getting the people that is sometimes hard on the phone. So I really appreciate this group.
Carolyn put hers in there. Yeah. Poor Carolyn. I've had her number in my phone for some time now. She's no stranger to my random calls, texts, and again, also very generous.
I'm always happy to answer questions. Sorry, I'm chasing after my dog who's digging holes in my yard right now.
We only have a couple minutes left here. So I'll share just in the vein of the heparinization plan. That was really interesting what Carolyn put out there in terms of heparinizing your blood prime as well. That's not something I've historically done. And mainly I blood prime my TPE sets because I've only got the large kit for that. I haven't blood primed or needed to. I've gotten away with a few other strategies on some of the other modalities. But what I do anyway, and for better or worse, I've got the circuit heparinized with and while it's being primed, I've got a little bit in there from the pump itself on whichever device I'm using. And then I'll actually administer my bolus directly to the patient through the catheter at the time. While I'm unwrapping or accessing the catheter and scrubbing and prepping it and pulling out Hepalox if it's been in for a bit and all the rest of that. I get my ACT from the catheter, and then I give my bolus at that point. And I'm pretty liberal with my heparin and my targets because I've had enough challenges due to clotting, so I err on a little bit of the higher side. I actually like 200. I know I tell when I teach and when I talk about it, 1.5 to 2 times normal, and so that 180 or 220 in that range or whatnot. But 200 makes my heart a little bit happier. So I'll start, and in dogs again, we learned like with subsequent treatments, how they responded. So in these one and dones, it's not quite as applicable, but certainly you learn kind of what their response is, and you get a sense of how hypercoagulable they might be with subsequent treatments. But I'll give in a dog a 50 unit per kg bolus at that starting place before I attach them to the circuit, just so I know that I've got them in a place where, you guys all know, right as you're getting on the pump, the device, whatever modality you're using, like that's when all hell's breaking loose, right? You've got your access pressures, your patient's starting to get fidgety, or they're reacting to the sudden blood flow through their catheter. Like I just like to take one element at least out of the foreground in terms of the coagulability and the anticoagulation plan. So I'm a little bit more aggressive at the start of mine. That comes with risks, obviously, especially if I've just placed a catheter and, there may be some oozing in this dog with GI stuff, maybe I'm going to, contribute to some of their GI bleed as well. So there's some consequences, and there's some considerations and altering of the plan to fit the individual patient. But I'm pretty aggressive right at the front end of it, just so I can focus on all the other bells and challenges that are coming from the initiation of the treatments and take that a little bit out of the equation, I hope anyway. I don't know, Drew. Yeah.
I'm going to agree with you in our strategy, just as another point of view. We do the same thing. We're pretty aggressive. Most of our patients get a 50 unit per kilo bolus. We generally will recheck that ACT, and we'll keep rechecking it and bolusing until we get our ACT, usually at least above 160 to start. In that blood prime I was talking about adding the heparin, it was on top of that. We got the patient's ACT above 160, and this is just for the revive, blood priming the revive. We don't necessarily add it for when we blood prime our TPE or anything like that. But I actually added the heparin to the blood as well, on top of having a patient with an ACT above 160. Because yeah, we won't start our sessions until they're above 160, because I agree with you, like 1,000%, most of your problems are going to happen at the very start of your session. And there are going to be starts and stops and starts and stops, which is when you're most likely to get your clotting. But if you can get them on smoothly and with minimal clotting at the start, at the back end, you're going to have a lot less trouble, I think. And that's just what I feel like experience has shown me over the last few years, is that if I can get them on smoothly, most of the time I can get through at least 3/4 of a session without any problems if I just take care of the heparinization at the start.
And that's a really good, I may have to, modify. I don't often recheck it after I give that initial bolus. I feel 50 is generally pretty solid. And that's in dogs, in cats, I'll go about half that.
So we have found with the Revive pump, because we're treating a lot of really young dogs, we're finding that puppies, anything under 2 years of age, tend to be very clotty. A lot of them, their ACTs starting out are 100 or below. They're usually like between 80 and 100. And we've had to give like upwards in boluses about 100 to 125 units per kilo in order to get them on. So we recheck it.
I mean, that's like what we had. This dog's baseline was 70, and we gave a 50 unit per kilo, and it came to 130. We unfortunately made a decision to start, but then had to give probably another like 100 units per kilo to get us to a place that we were okay and clearly above 160. I think we hung out between like 180 and 190 most of the treatment.
Yeah, and our heparin CRI, I think at one point we had it at 70 units per kg per hour.
Yeah, like it was kind of ridiculous how clotty this thing was, which is also like a new component of this process for us too, all in this case. Like we've had other dogs that are like a little bit clotty, but not that clotty. This one was really clotty. I actually think he has a thrombus in his back leg right now from a previous drum line that we placed peri procedure for sampling, and he is just edematous with like pitting edema and some redness in that back left leg that I think is probably just a complication related to thrombosis, but that's not his problem today.
But reflective of his systemic inflammatory, disease, and I bet with what you described there, coming through the door, there was already something more brewing by the sounds of it.
I blame his pancreas. I think it was already more. We didn't stop detect the pancreas before we got him on the device, but we checked it pretty shortly thereafter, and I think he was pretty hot pancreatitis coming in the door.
Yeah, it sure sounds like it. So I mean, you guys had a lot of factors working against you there, but do you still have the catheter in?
The dialysis catheter?
Yeah.
No, because we had already pulled it out to be able to complete the procedure with decent flow rates. We pulled it that night, and again, we presumed it'd be a one and done type of a therapy. Given that we were treating carprofen, I think in hindsight now we've got the preliminary cartridges, and could we try to go after all the cytokines that are probably wreaking havoc on the rest of his body right now? I don't know. That's a conversation for probably a different patient.
Yeah, and in my head, I was, thinking of the if his azotemia continues, and that's another pathway. I would have not had it in there either. I don't leave him in for the 5 days or anything like that either. But I was just curious. Oh man. Well, Drew, this is like again, the fact that you guys are comfortable enough to share. I think it is important. Like you touched on, we publish and we talk about all the great successes. And so maybe there's a little bit of a loss of recognition of the stuff that all goes to crap. They do, and they do for everybody. And so it's really good. It's good to highlight that in ways in the safe kind of form, and for you guys to kind of throw that out here. I think is really helpful for everybody else to kind of refresh and learn and kind of think through how they might go through some of those challenges and recognize that, this isn't, always perfect. So I appreciate you guys bringing the case today and throwing yourself out there for feedback and support, both constructive as well as just in general. That's really, it's helpful for us to all learn from things that don't go so well, and make sure that we talk about those and not just all the great things we do. As much greatness as we are contributing to these patients. So yeah, so thanks again. And again, Carolyn's number, my number, in the chat. I don't sleep a lot, even when I'm not on clinic. So feel free, text anytime, call anytime. And
I appreciate that.
I don't know if anybody else that hasn't chimed in. It's noon on the dot. Does anybody else have any last words of support, wisdom, constructive feedback, or anything else related to the case before we sign off? Maybe not. Well, if there's space at the next time we get together, I've got a presentation kind of prepped for this cat, and I'll throw myself on my own sword as well, and tell you what I wish I would have done differently. And I don't know. I thought I did right by the cat, and the outcome was disappointing. So I'll share that story if there's space at one of the near future meetings as well. And with that, thanks for entertaining the fact that I'm here instead of Calgill leading the discussion, although you guys did most of the talking, which is perfect. And happy treatments. And I guess we'll see you guys at the next one.
All right.
Thanks again.
Thanks, Jethro.
Appreciate it.
Cheers, guys. Take care.
I usually end up